TopMedTalk.
Well, hello and welcome to TopMedTalk. We are here in Seattle, Washington, attending the 2024 Annual Congress of IARS and SOCA. I'm Desiree Chappell, and I'm joined today by my former co-editor-in-chief of TopMedTalk, Monty Mythen. Hello, Monty. I'm all choked up.
Where's Professor Mike Grocott when you need him?
Professor Mike, he's a busy boy.
Okay, he is.
Yeah.
And now I'm over in the United States of America, popping up the road from Southern California to Seattle in the state of Washington, not Washington, D.C.
That's
another country. Was relatively straightforward. But we actually came for the International Anesthesia Research Society combined with
SOCA, the Society of Critical Care Anesthesiologists.
A great meeting.
It is. Monty, you have a new role now.
So, I joined Edwards Lifesciences, the biomedical engineering company, as their Senior Vice President of Medical Affairs, August of last year. Yeah. But I am still an emeritus professor at University College London, and all parties agreed that I could sit in occasionally to interview. It was an appropriate subject. There was no major conflicts of interest.
We've been doing a lot lately. We're at SOAP meeting with the Society of Obstetric Anesthesia and Perinatology. Awesome.
At the same time, we had a team down under.
We did. TMT Down Under, TopMedTalk Down Under at the ANSCA meeting where you were last year. Yep. This year, representing TopMedTalk, Kate Leslie and Andy Cumsty.
Did a fantastic job.
If you have not had a chance to listen, you should listen to those immediately.
Very rich content.
It is. It's very good. They might put us out of a job.
Not the soap wasn't great too, but it was very rich, diverse content.
Yeah, it was very, very good. So we've been attending the meeting this time, Monty. Yeah. We don't have a booth in exhibit hall. We are kind of in a separate area recording now. But we thought, we
should qualify. By attending the meeting, we mean we've actually been here listening to lectures.
We get to go and we get to listen to lectures. We get to go and look at the posters, present a poster. I got to present a poster this time. I know. But we thought, we're here. I brought our recording equipment just in case. So why not seize the opportunity?
So we found a little room off the side somewhere.
We did.
Here we are.
Yeah. And so we invited our next guest, who is actually a former guest on TopMedTalk and a fan fave, and one of my favorite colleagues who I work with at NorthStar Anesthesia, Dr. Wael Saasouh. Wael, thanks for coming back.
Of course. It's a pleasure to always be here.
Yeah, absolutely. Wael, I think our last conversation happened to be at IARS last year. But for those who may not have listened to that podcast, why don't you tell us a little bit more about yourself?
Wael Saasouh, I'm an anesthesiologist out of Detroit Medical Center in Michigan, and I'm the Director of Research for NorthStar Anesthesia. I have a lot of interest in research, academics, recently more into the AI and the medical innovation fields, and big fan of the show.
Thank you. I feel so privileged to be able to work with you. NorthStar Anesthesia, in case you don't know, is a large national anesthesia company. We have almost 200 sites, over 200 sites across the U.S., almost 5,000 clinicians that work with NorthStar and part of our team. And it's basically community facilities. We don't really have major academic institutions that we cover, but we have everything from teeny tiny little one provider or two provider ASCs all the way up to major large community practices. And while bringing you on in the world of research and academic advancement was something that was new territory for us, right?
It is, and it's new territory for me as well, and that's what makes it more exciting, because now we're trying to build something which conventionally doesn't exist. Yeah. It's having an academic structure at a non-academic base. The motivation behind it is that there are a lot of clinicians at those non-academic sites who are interested in academics, they just don't have the infrastructure to work on it.
They've had academic training and experience.
Exactly. Yeah, but they choose to work at these sites, which is where a grand majority of the operating surgical procedures happen anyway. Yeah. So it's a very large chunk of the society, of the clinical society, that doesn't really get represented when we publish manuscripts, because most of the publications happen in academic centers where they have a very rigorous method of doing it. They have the infrastructure, they have the support and the funding and all that. So we thought it would be an interesting and fun endeavor.
So we're building it from the ground up, so that there's that. We're working on that. But
to that point, there were quite a lot of abstracts here. There always are, relatively fast turnover, very well done, very well attended. And some of the institutions have quite a few abstracts, understandably, because they've got tens or even sometimes hundreds of academics working at those places. While as a solo representative of NorthStar Academia, it was a bit bigger than that in a second. How many abstracts did you have?
I had 8. for this meeting.
Well done.
I know. I wish I had a round of applause.
Thank
I
you,
think
thank
I do on this. But...
I'll take it. It's exciting for me. It's and this is not just my work. It's the work of me and colleagues. So I'm happy to be representing all of them. We have a whole team of people working together to make these things happen. And I think all of this work deserves to be represented. Year after year, the work that we're presenting is showing some real good data, and it's showing progress in areas that have been stagnant for a long time academically. And I think it deserves all this attention, and we will keep pushing for it.
Well, and I do want to say, Monty, I didn't broach this issue, but we have affiliation with academic programs. Sure. We have a couple residencies that we are collaborating with within NorthStar, and you are a part of that as well. So a lot of what we do right now is all affiliated with.
Right, and all the research, everything that's above a simple observational or quality improvement study, everything that needs to go through IRBs and through compliance and through that goes through all the proper channels at the local sites. Yeah. So for example, at the DMC, I am affiliated with a medical school, and all my research goes through the IRB of that medical school. So it's we're trying to form more of a hybrid product where the people with the expertise can help with the logistics, and then the people with the interest can help with we're calling it research, but it's really academic advancement as a bigger umbrella.
So to get into your abstract, 8's a lot to go through, but as I was looking at them, I thought they fell into 3 broad categories. Is that fair? So I thought there were 6 of them, which we'll come to in a moment, that were in one grouping, and then there were 2 other more discrete ones. Do you want to pick those off for us?
So I would say one category was hemodynamics in general. One category which was new to me this year is financial wellness. And then the last one is on the fringes of research, I want to say. It's on survey research, and it's on patient-centered perspectives. So we can talk about those very briefly.
Well, let's pick off the IOH very quickly,
okay,
because everything we've talked about so far suggests that it's common and not necessarily good for you by association.
Right, and as an introduction to this topic in general and why what we're doing matters, we know from academic research that IOH is prevalent. We know it's about a third of all surgeries if we take the pre-op 31 measure, which is 65 millimeters of mercury below for a cumulative of 15 minutes or more. So that comes up to about 30% incidence. We did this whole work last year on community settings, and we talked about it, and it's still 30%.
It's all published.
It's all published. We have 2 papers out. The third one is hopefully on the way. I'd be happy to redirect the listeners to that work. But as we said last time, this is surprising because you'd think that community settings are easier to work in. The patients are healthier and the procedures are less complex. We still found enough hypotension to warrant some sort of intervention. So from those data sets and from our collaborations with some of the sites at NorthStar, there are 2 abstracts. One of them was a collaboration with our colleagues at the Norton Healthcare System. With
the Leatherman Spine Center.
Leatherman Spine Center. We looked at intraoperative hypotension and how it relates to surgical site infection and some other complications and after surgery. And not to go through the entire thing, but we had a little over 500 cases of thoracolumbar fusions, and those were the complex cases. So more than 6 levels, more than 3 hours. So those are the bigger surgeries. And they're not as well studied as you would think they are. And these are some fragile populations sometimes when it comes to hemodynamics and when it comes to complications. And complications matter a lot because they cause major issues afterwards. So we found some significant differences between groups that were hypertensive versus ones that weren't hypertensive. For example,
in terms of outcomes.
Surgical site infection requiring IND, PEs, acute kidney injury, GI complications, cognitive dysfunction afterwards, pulmonary complications in general as an umbrella. So it does matter, and we can assume that it does matter without knowing the data, but the data didn't exist to show exactly how much it matters.
So not to just say too much about it here because we want to get onto the other subjects, but pathophysiologically, that clustering of complications makes sense and is a recurring theme.
Absolutely.
Yeah.
But in spine surgery, this is new, I think.
It is new. It's new in the field, and it does make sense.
And the paper's out, isn't it?
It is. We're just published.
Yeah, it is published in the Spine Journal. Yeah,
we'll get it in the show notes.
Yeah.
Absolutely.
Dr. Steve Glassman and Dr. Leah Carrion and Dr. Milan Djurjosevic and Dr. Jeffrey Gum. I have to give them a huge shout out. Yeah. All of them have been
surgical colleagues.
They are my surgical colleagues. Yeah, that'll work with
spine surgeon colleagues publishing about IOH and outcomes. Fantastic.
Yeah, in a spine journal, which is
a spine journal. So so this is one good example of what kind of collaboration we're aiming to have between anesthesiologists, CRNAs, surgeons. Quality improvement doesn't come from one side; it has to come from multiple sides. And this is a very, very good example. And expect to see a lot more from this group specifically and from similar groups.
And is your second one directly linked to that?
The second one looks at how IOH is managed between patients who had intensive monitoring versus for those who didn't, continuous monitoring. And then it's a natural continuation of what we did here.
It may not be in this one, but when we're at the World Congress, Desiree, you presented data where your pilot work suggests that you've not fixed, but you've made a big difference to the problem. You've interacted. Things have changed.
Yeah. We looked at 45, almost 50 cases, 50 patients, and utilizing the HPI index, the hypotension predictive index, and hemodynamic monitoring, we were able to reduce intraoperative hypotension, thereby reducing the complications that in a significant way that Wael just mentioned.
And is that published yet?
Not yet. It's on the way.
So the abstract, I think, is accepted for the HASS. I think I found it online.
Oh, it is. Yeah. Let me, I'll think about
spine surgeons. I think it's in November. I'm ahead of you on this.
I know. I was just going to say, yes, you caught me flat-footed. But yeah, well, I'm thinking because we had a couple that we did. Had submitted those, and
it gets understandably confusing.
It does. We have a lot of moving parts right now.
Let's leave IOH alone for a little bit. And you've got a paper under review about peri-induction drops in blood pressure. Let's hear about the other two areas, which I think will be new to our listeners.
Yeah.
So one of those is financial wellness and anesthesia, and this comes from a very new endeavor that I'm interested in, trying to look at what kind of data exists that links financial wellness to actual wellness in the field.
Specifically looking at for anesthesiologists.
For anesthesiologists.
Yes.
So there are plenty of blogs and websites and a lot of financial advice in medicine in general. Those have become much more popular over the last year or two. Generally speaking, a lot of it is opinion, a lot of it is personal experience. I haven't seen a whole lot of actual data to support all of that, although it all makes a lot of sense. So I have collaborated with a financial lending company, and they were interested in also adding a scientific reasoning to the topic. So they had the data, and arguably it's a biased sample, but it's the only thing I've found so far that has concrete data. So we looked at, naturally, because of the lending process, those companies will have FICO scores. They will have the application forms.
Yeah, FICO scores.
So a FICO score is a Fair Isaac Corporation score, which is a metric by which lenders measure the credit worthiness of a borrower. If you have a good FICO score, which is typically in the 700s and 800s, then you're probably a good candidate because you can pay back the loan. If you have a low score, which tends to be in the 600s or less, then you're more likely someone who will not be able to handle the extra debt from the loan. So they wouldn't give you a loan, or they would give you worse interest rates, or they would give you worse terms.
And that credit score is made up of a lot of different things.
A lot of things.
We're all used to that. But I mean, a lot of things can impact that, one of which is not having a lot of credit.
Credit history.
You don't have a credit history.
How much do you pay back your repayments on time? How much debt do you have right now? How much income? Income doesn't go into it, but then there's a metric that involves it.
So you just qualified as let's take a doctor example, but for all clinicians, it's the same gig.
Yep.
You tend to have big university debts. You're often not that good at paying your electricity bill, your gas bill, keeping up to date with things. And so now you're effectively broke with a terrible credit score, but your projection is you're going to earn a lot of money.
Exactly. And I can speak from experience, and that's what piqued my interest in the topic. When I first started my journey in the country, I came in as a graduate of anesthesia, but then I was starting as a research fellow.
Yeah, because you're from Lebanon.
I'm from Lebanon. Yeah. I was an anesthesiologist there. I decided to move here. So I had zero credit history. And then when I started, of course, things cost a lot of money. You don't make a lot of money being a research fellow. So very quickly, I accrued a whole lot of debt. Yeah. And I applied for a lot of things. First of all, I couldn't get a personal loan because I was not a citizen.
Yeah.
And second, there were only two institutions that were...
I couldn't get one.
Well, there you go.
Oh.
So I came on a visa to work in the United States of America recently. I'm relatively old.
I feel you said it.
Young at heart.
You kind of think I could get a loan, or I can't get a. No, I don't need a loan, but
because you don't have like a U.S. credit.
They wouldn't give you a credit card. And you have to pay up front. Up front, you can't have a promissory deposit on anything. You have to pay everything cash up front.
My first credit card had a limit of $500. And it was a secure credit card, which means I had to give them $500 in cash. They would give me a card that would let me spend up to $500. It does, because that's how you start building your credit. So anyway, people, especially who come to the country and they're at the start of their career, so say they match in residency, they don't have a whole lot of options. So 2 places I found that would give me a loan, and I use them both. And the one of them, called Doc-to-Doc Lending, is a group that Doc-to-Doc. So DOC, number 2, DOC.
Cool name.
Yeah. This was founded by clinicians because they realized that this is a problem. And the one thing they do uniquely is that they don't look at you right now and how creditworthy you are. They look at where you're projected to be after you graduate, which non-medically oriented lenders don't even look at because they don't know. To them, it doesn't make sense. So for these guys, you're going to become an anesthesiologist or a cardiologist or a surgeon. Your income is going to be a little more than $50,000 a year. So you should be able to pay back a loan within restrictions. So to keep the long story short, I stayed on with them after I graduated. I'm consulting with them, disclosure. I'm consulting with them to make sense of their data. So we formed this scientific research committee, and we started just looking at the data to see what we can find out. So for example, by our estimates, more than 50% of U.S. medical schools will cost roughly $275,000 or more. On top of that, you have all sorts of expenses. But then you finish medical school, then you go into residency. Speaking about the medical side of things, residency is 4 years. After residency, you have, say, maybe 1 or 2 years of fellowship training, still at a very limited income. So the amount of bad credit that you accrue, unless you were lucky enough to be born into a wealthy family, is significant. And then you definitely need some assistance with that. But then you know that after you're done with this, you're making a decent amount of money. We assessed the credit profiles of anesthesia trainees and how that changed after they graduated. And it was pretty interesting because from our perspective, we know, I know personally that I was a very bad pick for a loan for almost all lenders. So we saw that the difference between FICO scores as a median, we have about 293 anesthesiology trainees and attendings between 2019 and 2023. And the median FICO score of the trainees was 690 and of the attendings was 724. So we started with a significant difference when it came to the data.
What's a pass mark?
I think if you're anything under 700, you're generally looked at as low score. But then we had some extra data. So now we tracked the FICO score from the median of being a trainee and then 10 years into practice. And we saw how it evolves, arguably for this sample only. But still, we saw that within 5 years, you have a significant jump in FICO scores from being a resident, which typically coincides with you graduating and starting a career. So for a lender to see this, they know that in 5 years, you're going to be more than able to pay this back, which should change your credit worthiness to them. We also looked at why people request these loans to start with, and a grand majority of the trainees wanted for credit card consolidation, which also makes sense because they can't do loans.
So they have to put everything on a credit card.
Right. And
you're paying exorbitant rates.
Exactly, 20 to 25%.
Yeah.
So if you can get a loan for 8 or 10 or 12%, that's already a win for you financially. And then when it comes to attendings, then
sorry to drop one.
Relocations.
You think the lenders would kind of think, come on, these people are a good bet. But now I'm reflecting on that and thinking, you talk computers now these days.
Well, even if not, the lenders traditionally look at you right now as a snapshot. How are you faring right now?
But not with the human twist to them.
Not with the human twist. So this was the unique thing they did.
They asked the algorithm.
Absolutely.
Because I reflect on when I qualified as a medical student, I was a terrible risk. But I knew my local bank manager who talked to me as a human being and said, you're obviously going to be all right, Doc.
Yeah.
Exactly.
We'll help you get started.
Yeah.
I came back from the United States of America when I was now talking to, in the late 90s, early noughties, talking to a computer now, and the computer said no.
Yeah.
I mean, I was relatively wealthy by that stage, and with no debts.
Yeah.
And now I come to America a lot later, and the new computer said no. So is that roughly what we're speaking?
That is pretty much it. And this is the formalized version of you talking to the bank manager.
Yeah. Okay.
Because that person understood that your situation isn't the typical situation of somebody who's trying to borrow money.
And they didn't gouge me for interest rates because they thought, well, I might stay with them for life.
Yes.
But I mean, if no one's looking at that data, if the banks aren't looking at that data specifically the way that you've looked at them to understand that you would actually be a good risk and you would be somebody that you would want to bank with you in the long term.
And if you think about it, this is a group of clinicians who started this. So they're supporting another group of clinicians, and then that new group can become a source of support for the company. So it's a good model, and it's a good business model, and it's working.
Have you made the link to personal health yet? Or is that coming?
That's hopefully coming. We did the analysis on a bigger data set within multiple specialties. We're only presenting the anesthesia portion of it, but the bigger analysis is actually being written up. Another challenge, because now where do you publish this?
Yes.
Not all journals will accept it as a topic because not everybody knows how to handle the implications of this kind of research, and not everybody is interested, frankly, to post it in a medical journal.
I think you should think about sending it to A&A practice.
Yep.
Yeah, we just interviewed the editor-in-chief of Anesthesia and Analgesia, and I think I can't promise on their behalf.
No.
We made very clear that they'd look at anything new, new space. No promises it will get published or anything, but I think you should send it in.
Absolutely. And being at this conference, it really opened up a lot of venues for discussion with editors to see how we can start promoting work like this, because it doesn't really exist, and it would be nice to be the people who make it happen. And I think they agree.
And if not that, the Wall Street Journal maybe. So the second big buckets, I think, of which I think there were 6 abstracts.
The third big bucket, yes.
Third big bucket.
So also something that's not traditional in research, or not traditionally as advertised in research, which is survey research. A lot of people have...
Why isn't survey so much? This is one thing I don't know.
Some get through, but I'm with you.
Some get through. The problem with survey research is, traditionally how you do it is, say you have 100 patients that were discharged from your hospital within the past 30 days, rough number. And those 100 patients, you send them surveys and you want them to respond to whatever question you're asking them. If not 60 to 70 of them respond, if you have any less than that, then your results aren't really representative of the bigger sample. So it's kind of looked down upon as not a very high tier of evidence.
Okay.
So to challenge that now with this work that we're doing, there's another company called Riwi, and they do Riwi, R-I-W-I.
R-I-W-I, Riwi.
Yep. And it stands for real-time worldwide intelligence. And the way they do it is they send out these electronic surveys to populations at a time. So you're not sending it to specific people. So you don't really know.
So Wael, Saasouh, who had surgery last week, it's not necessarily for you.
I'm sending it to all the IP addresses within the United States.
Yeah, okay.
And
so it's you that's doing that too.
I'm the one who's doing that. And it doesn't go to an inbox. It pops up as you're browsing, and you choose to participate or not.
Do you want to take this survey?
Or not.
Yeah.
And the interesting thing is, you can see the limitations on that because you don't know who's filling out the survey, but then they compare the respondents to census data to see if you got a representative sample of the country.
Gotcha.
Which I think is very powerful. It's very crucial for us when we're doing formal research with that data. So we've done a couple of projects with them so far. The first one was to gain an insight on patient perspectives on perioperative care. We always say, we think this is the best way to move forward. We think this is what patients need. We think that this is what matters to them. We don't really know exactly what matters to them unless we ask them directly. So that was just the proof of concept. And I sent out 15 questions. I got 1,000 responses in 3 days.
3 days. I know.
And
you told me that. I was like, what?
So it's a very powerful method if we want to get real-time feedback. If you send a regular survey, it's going to be months before you can analyze that data.
And give us a few headlines from what you found.
So from what we found, we naturally focused on patient-reported outcomes. We looked at how satisfied they were with how they were prepared for surgery, how they were prepared for recovery, how long it took them to return to baseline function, versus multiple things, including level of education and what kind of surgery they had. We looked at what else they would to know or have before they had the surgery that would make them better prepared. And we got all sorts of interesting answers. So for example, patient desires preoperatively, what would they want? And we asked them, would you like more education? Would you like some emotional supports? Would you like to meet the representatives of your surgery, the anesthesia clinicians, the surgeons, the nurses, or none of the above? The grand majority said none of the above. I picked those answer choices because I thought those are the most important things. And this is how we do our research. But the grand majority said none of the above. Now, I didn't do an open text answer because it would have taken a lot more computing.
And well, just to be clear, the surgeon was on that list.
Everybody. So I lumped representatives in one category. So representatives included surgeons, anesthesia clinicians, nursing, anybody from the hospital who was directly involved in your care. Would you want to meet them beforehand? Didn't seem to care. The one spike I saw was in the 25 to 35-year-old category. And those are the people who said they could benefit from some emotional support before the surgery, which I thought was interesting. Quickly going through some other metrics here. What types of surgeries did we capture? We captured joint surgeries, abdominal surgeries, chest, and brain and spine. And the rough representation was about a third for joint, 15% for chest and cardiovascular, 20% for brain surgery, and then about 30-some% for abdominal surgeries. I also looked at where did they come from and where did they get discharged to. So most of them came from home, went back to home. But then there's a good chunk of people, 19%, who were admitted before the surgery and then they were discharged home afterwards, which is great. But then you get 17% who came from home, had their surgery done, and then had to be discharged to a facility. Not even into the hospital. They had to go to some long-term facility.
Well, 17% seems...
That's a lot.
Does it seem high?
It does seem
I'm
high.
not surprised.
And we always take it with a grain of salt. It's an anonymized survey. We don't have any PHI in there. We don't have a way to confirm all of this. But I don't see a whole lot of reasons for people to not represent the truth, except for recall bias. That's the only thing I can...
And we've had a side conversation about this because I looked at it fairly closely with you, and I've satisfied myself that all the natural questions about biased samples and non-representations looking pretty solid.
Yes, and the company does put in a significant amount of effort to try to avoid all of those things. Bot answers, random answering, or when people answer the same thing all through, they try to filter that out. So if there's any doubt of it, those answers don't get counted in the final analysis.
So there were 6 papers in this, abstracts in this bucket. What were they? We don't have time for all of the other 5, but the headline results shock us.
Okay.
Because we're already shocked and not bothered about seeing the surgeon, let alone the anesthetist.
So we asked, did you think that the info you received prepared you for recovery? And about a third of them said no.
No.
A combination of disagree and strongly disagree.
Yeah.
And the implications are obvious. We asked about how long it took them to return to baseline function after surgery. And the general knowledge here is that the higher education level you are before surgery, the more likely you're going to recover better and faster, and you're going to take care of yourself and you're going to report complications. I found a bimodal spread here. So people with low levels of education did worse. It took them longer to return to baseline function. People with master's degrees or higher also took longer to recover. Theory here being maybe they need a whole lot more to return to what they consider as baseline. So say you had a major abdominal procedure and you're an astronaut. You're not going to return to your baseline function soon because you need to get rehab and all those things. Food for thought.
How long did you get a sense of how long the recovery took?
The ones who took long were 6 months or more.
All right.
Yeah.
We also looked at the use of analgesics, and it's not just opioids, it's analgesics versus how long they were in pain after surgery. And this was actually a surprisingly positive result because we saw that the more pain they were in, the more they used analgesics. And what I was looking for is people who didn't have any pain anymore but were still taking analgesics, and I didn't find much of that. So that was encouraging. And
there's a potential for bias one can see there.
Absolutely.
Yeah.
Absolutely. One thing was...
We're all agree on that.
Oh, yeah. Sure.
There are
Speaking of getting narcotic, you're probably not going to fill in the questionnaire. Sad, but
we also looked at the duration of analgesic use after joint surgery. 30% said they use it for less than 1 week. And I'm saying analgesic as an umbrella. Again, opioids and non-opioids. But then I have about 25% of patients after joint surgery were on analgesic 6 months or more afterwards. And here you start thinking about what does it mean to have a successful surgery? For the surgeon, it's the joint is fixed, everything's fine. For the anesthesiologist or anesthetist, it means they recovered, they woke up, they left the recovery room, they didn't get admitted, no complications, everything's fine, they didn't get readmitted. For the patient, it means I'm walking, I'm doing my activities of daily living.
And I'm not in pain anymore.
Exactly. So hence why we're trying to have a patient perspective on all of this.
Yeah, I love it. Great.
So overall, this is what we've been presenting for this meeting. I have another project with them that's currently in the process of being analyzed, so I won't give away too much, but maybe you'll read it in ANA.
Love it.
We'll see.
Yeah, that's great. Anything else, Monty? Any other big question?
Related to your first thing about intraoperative hemodynamic instability, and this is a bit of bias here coming from my position at Edwards, because I think we awarded you, I don't know if you've received it yet, a grant that you requested to look in this space about attitudes.
We're still working on that.
Yeah.
It's naturally there's a lot of paperwork that comes with projects like this.
So what was the big question?
The question was, we want to find out if patients care about what we're doing in a big umbrella. So in a very broad sense, do you care that I'm employing these advanced monitors to measure your blood pressure? Do you want to know what kind of blood pressures you were having when you were here?
Do you understand the question?
Right.
Do you?
And that's not undermining people. But
No. It's a 100%.
A lot of people will have their hospital experience as this big black box. I just go in and come out and hope I'll be better. I want to ask people, does it matter to you if I tell you that your blood pressure was low, given the risk that comes with that? So we don't really have that data, and I'm trying to utilize this technology to kind of ask the general population. And my bigger aim is to do this internationally and then to find differences between countries, but more on that later.
Yeah, love it. Wael, congratulations on all the amazing work that you're doing here and the posters that you presented. And I'm glad that we've been able to do a couple together. That's been a lot of fun. And all the work that we're doing, stay tuned to hear more about that. I'm sure we'll have some more opportunity to talk about
I will try to mention it first here.
Yeah, that's good.
Yeah.
We're late breaking here on TopMedTalk.
Yeah.
And so thank you so much for taking the time
guys.
to sit down with us. And thank you for listening to TopMedTalk. Monty, you can always listen to us at TopMedTalk.com. We are on your favorite podcatcher. We're on social now, YouTube, right?
Yeah. And X.
Oh, yeah, X. X, LinkedIn, Facebook.
What is that?
We're there.
That's Twitter, isn't it?
That it's formerly known as Twitter. Yeah, that's like Prince, or no, P. Diddy, one of those. Anyway, it's they're formerly known as.
Yeah.
Do you get it?
Purple.
Yeah, that's one. Anyway, you can find us YouTube. I want to tell you about YouTube really quick. Give us a thumbs up. Subscribe to our channel. Every little bit helps. It's a new foray for us. We're getting into a new space, so let us know what you think. And be sure to listen to those ANSCA, the TMT Down Under pods.
You're
They're
going
really
to
good.
the ESAIC in Munich?
We are, yeah. I will be at the ESAIC in Munich, their annual meeting and Congress there, and then we'll be in Prato.
So the Global Trials, Monash Global Trials meeting. Then what after that?
Palm comes up this summer. I know we have the. I'll be at the AANA this summer as well. So we have lots going on.
It's a busy year.
We'll be around. You'll see us. Come and say hi. All right, cheers, everybody. Have a great afternoon. Bye.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.